value of serum levels of interleukin-6 in patients with elevation of
Good afternoon. Thanks for the organizer and the selection committee which they have selected my paper. Thanks to my professor Dr. Subramaniam, who is constantly in touch with atherosclerosis progression and pathology. And this is the topic, actually burning topic. This is the first in India actually topic. He has inspired me. This is the prognostic value of serum level of interleukin-6 in patient with ST segment elevation. Our objective is to evaluate the serum level of interleukin-6 as a prognostic value of major clinical in-hospital event in patient with STEMI. So just one or two slides about the background of the interleukin-6. In the recent years, a lot of study has been shown that inflammation and the immune mechanism take part in the pathophysiology of the atherosclerotic and plaque rupture, which leads to genesis of the acute coronary syndrome. So the interleukin-6 plays a key role in atherogenesis as well as the most atherothrombotic phenomena such as ST segment elevation MI. Interleukin-6 is ubiquitous cytokines may enhance synthesis of endothelin, which is from the endothelial cell and from the macrophages, resulting increase in smooth muscle cell reactivity and endothelial cell activation. This interleukin-6 plays an important role in the acute phase response, that is because it induces the release of C-reactive protein and which involved in the progression of atherosclerotic plaque together with oxidized LDL, fibrinogen and TNF-alpha. Interleukin-6 expressed at the shoulder region of the atherosclerotic plaque and increases the plaque instability, that is the vulnerable plaque, which is important for the acute coronary syndrome, and by which thrombus formation by driving expression of the metalloproteinases, metric metalloproteinases, and MCP and TNF-alpha. So, in brief, interleukin-6 increases the fibrinogen level, increases the CRP level, by macrophages it increases the tissue factors, MCP, that is monocyte chemotactic proteins, MMPs, and by activating the platelet it increases the aggregations, and adhescence molecule, it increases the adhesion molecule interleukin beta and TNF-alpha, and it increases the proliferation of the vascular smooth muscle cell. So what we have done is we have all the patients admitted with acute MI, ST elevation MI, which is the criteria by the ACC, AHA and ECS guidelines. We have taken a sample, blood sample, serum sample within 24 hours of that MI, and we have measured interleukin-6 by ELISA technique. Within that we have collected the blood, and within 24 hours of the acute event we have collected. Then we have studied the major cardiovascular points, that the endpoints are arrhythmias, angina, heart failure, and rear fraction, and death. And actually everybody will think that this is so much important about the biomarker. The cost is only 20,000 only. Per test it may be 300 rupees. We have excluded the acute infection, systemic diseases like rheumatoid arthritis, SLE, cardiomyopathies, valvular heart diseases, congenital heart disease, and neoplasma, or chronic renal failure, pregnancy associated with acute MI. This is the we have totally done the 86 patients, out of which we have divided 86 patients into two groups. One group having interleukin, we have taken an interleukin of IL-6 value of 20 picogram per ml. 20 picogram per ml if it is less than 20 or more than 20. We have divided into two groups, where group 1 is having interleukin having less than 20 picogram per ml, and group 2 having more than 20 picogram per ml. So we want to know that if the interleukin is high in group 2 and we have compared with group 1, what are the endpoints we want to, and mean value of interleukin-6 in group 1 is 11.52 plus or minus 4.82 versus 63.19 plus or minus 44. So group 2 more than 20 per ml. Baseline characteristic of group 1 and group 2 is 56 plus or minus 18. Group 1 and group 2 non-significant, males, females, Males in group 1 72% and 27%, and group 2 it is also 68 31%. So baseline characteristic of the both A and B groups are same. Risk factors, though it is very common that diabetes is in group 2, the population diabetic is 52% compared to group 1, which is having less than 20, but hypertension, dyslipidemia and smokers, we have compared both the groups are same. So lipid profile we have done at the time of admission and at 2 months of after 2 months of discharge. The total cholesterol at the time of admission, group 1 and group 2 is approximately same, and LDL triglyceride is little bit higher at 2 months, 144 plus or minus 72 and 136 plus or minus 60. We want to correlate even the serum cholesterol level at admission at 2 months, which is correlating with the prognosis or which is correlating with interleukin 6. So the clinical and hemodynamic presentation, the patient's presentation, the patient's group 1 which is having less than 20 picogram and more than group 2 which is having more than 20 picogram, it has been seen that group 1 patient class 4 CLIP classification is 2.1%, wherever group 2 it is 11.8%. So more interleukin, more CLIP class 1. It has been seen that LVEF, which is we have taken more than 45 and less than 30, it has been seen clearly that more interleukin level is associated with ejection fraction less than 30%. We want to correlate even the CPK-MB, which is anywhere it is correlated with the interleukin 6. It is the CPK-MB is of even in group 1 and group 2 is almost same. Ejection fraction, which I have told, more than 32 patients are in group 1, and it has been seen that less than 30% is more prominent in group 2, where the interleukin 6 is more than 20. Angiographic, all the patients we have done, depending upon the lesion, some patient might have a double vessel, single vessel, LAD lesion 51, 55, circumflex 30 and 25, and unknown means we have not done any angiogram, so we don't have because of some other reason, because serum creatinine high or LVF, so in that unknown. It has been very clearly seen in our study that the thrombus burden is very, very high, which is significantly high in interleukins with patient having more than 20 picogram. So 49% and wherever 21%. It has been seen that single vessel disease, double vessel disease and multi-vessel disease, it has been seen in our clearly that multi-vessel diseases are more common in group 2, where the picogram more than 20 picogram in group 2, and wherever compared with low interleukin 6, the single vessel and double vessel are very common. The treatment part, what this patient got the treated, 70% got the thrombolysis for the group 1 and 53% thrombolized by the group 2 because of main factor in group 2, where 53% is because they have presented more than 12 hours of their presentation. For these patients, primary PTCA only done with only one patient, wherever 3 patient has been done with the group 2 patient. The very important is PCI, which these are all RHS patients. Less than 7 days we have done PCI in 18%, wherever 12% having PCI in group 2. So more than 7 days, 14 patients we have done in group 2, wherever 8 patients. The patient, they underwent CABG 9 or 10 in group 1 and group 2. Medical management, because coronaries are not suitable for PCI and CABG, 4% in group 1 and group 2 7%. So the risk analysis after the treatment, clinical feature and all these things, risk analysis, arrhythmia is more common in group 2 patient, where compared with group 1 patient, that is more than 20 picogram group 2. Recurrent angina, recurrent MI, which is significantly high in patient with interleukin 6 more than 20. And patient developed LVF. This is all in hospitalization. LVF developed is 12.8%, wherever 4.6% in group 1. Combined final endpoint also it is 51% in group 2, and group 1 it is 21%, which is all the risk analysis, complications, and during hospitalization also significantly high in interleukin 6 more than 20. So follow-up, we have done follow-up with 30 days, 6 months and 1 year, and follow-up also shows that POBA and PTCA and required CABG are very frequent in group 2 patient, and patient died, all 6 patients which have died in 1 year of follow-up, 2 are in PCI group and 4 are in non-invasive group. They are more common in interleukin 6 more than. So by conclusion, ischemic heart disease is closely associated with inflammatory disease, and different kinds of cytokine participate in the progression of atherosclerosis. Interleukin 6 is the main key part in the process of erythematous plaque, with the venerable plaque, which is the shoulder of the lesion, it is present, and increasing inflammatory cytokines, interleukin 6 level and the serum can be valued by the index of instability of the coronary atherosclerosis. Elevated admission of interleukin 6 well correlate with the LV dysfunction and CLIPAS, and elevated interleukin 6 well correlated with the angiographic multivessel disease and thrombus burden, and interleukin 6 also significantly associated with frequent in-hospital outcome like arrhythmia, angina, recurrent angina, and LVF and death. Follow-up at 1 month and 6 months and 1 year shows that patient higher level of interleukin more prone for restenosis, and this is also correlated with the Frick study, and admission level of interleukin 6 significantly higher who died of all these patients who are died, they are having group 2 patient, and this IL-6 was an independent predictor of cardiovascular mortality during 12 months follow-up in this STEMI patient. So finally, the use of inflammatory marker for the risk of stratification appeared to identify the patient with high risk of future event. So the present study of our study indicates that the elevated admission of interleukin 6, which provide a valuable information for the long-term risk stratification in case of ST elevation MI. Thank you for my